Stellmacher. I'm in the Women's Health Pathway, and today I'm going to be talking about care of the pregnant patients for the internist. The objectives for my talk are going to be able to counsel patients considering becoming pregnant, identify common teratogenic medications during pregnancy, describe diabetes and weight management for patients considering becoming pregnant or who are pregnant. And that's it. Why should we care about pregnant patients when we're internists? Well, there's quite a disparity in outcomes for women who are pregnant between socioeconomic and racial groups within the US. Specifically, 700 women die each year as a result of pregnancy or delivery complications. And Black, Alaska Native, and American Indian women have 2 to 3-fold increased mortality rate of white women in the United States. And for every one woman who dies, there's 70 additional severe maternal morbidity events that happen in pregnancy or in delivery. 16% of pregnancies are also exposed to teratogenic medications in the 12 months prior to conception, and 5% of pregnancies were exposed to a teratogenic medication during pregnancy. So these are opportunities for us as internists to really do preventative care and make sure that we're helping our patients have the healthiest pregnancy that they can when we see them before they become pregnant. We're going to go through a few cases here. Case 1 is Phoebe Buffet. She's a 34-year-old woman who's considering becoming pregnant. She plans to be a surrogate for her brother, and she would like to know how to increase her chances of carrying her brother's pregnancy through intrauterine insemination. So first, we're going to talk about some preconception counseling. ACOG recommends that at any preventative care visit that we ask our patients if they are planning to become pregnant in the next year. And they recommend using the broad phrase, "Would you like to become pregnant in the next year?" Overall, the goal of pre-pregnancy care is to reduce the risk of adverse health events for both the woman, fetus, and neonate by working with the woman to optimize health and address modifiable risk factors and provide education about healthy pregnancy. Oftentimes, how I've been taught about thinking of these visits is to think of it as a medical consultation, optimization, and risk management for patients in the preconception period. Oftentimes, the first thing we think of is counseling women on giving them a multivitamin with folate. Specifically, it's 400 micrograms. Usually that's included in a prenatal multivitamin, though a patient should probably ensure that that is in their prenatal multivitamin if they're taking it. Patients only need an additional amount of folate if they have had a history of a pregnancy with a neural tube defect, or if there's a family history of neural tube defects. Though most women aged 15 to 45 do have an adequate amount of folate in their diet. Patients should also have their medications reviewed. Specifically, we should be thinking about, are the medications that the patient's still on still indicated currently? Can the symptoms or disease that the patient has be amenable to non-pharmacologic management? Specifically thinking, for some examples, like asthma or depression, thinking of alternative measures if the patient is well controlled or can de-escalate from their medications. And then also, what would be the effect of not administering the med during pregnancy to both the mother and fetus? So thinking about depression, would there be uncontrolled symptoms during pregnancy that would lead to unfavorable outcomes if the medication was discontinued? We also think about genetic testing and history. ACOG recommends that you provide the same genetic testing to a pregnant woman that you would provide to a non-pregnant woman, and also asking about family history of genetic or congenital abnormalities or diseases of both the partner and the woman. Also thinking about cervical cancer screening and making sure that a woman is up to date, as uncontrolled or undiagnosed cervical cancer during pregnancy relates to significant morbidity and mortality during pregnancy. Patients should also have their immunizations reviewed. Specifically, live vaccinations should be given prior to pregnancy as they're contraindicated during pregnancy. And more commonly, HPV vaccine should also be given prior to pregnancy and should be given at least 1 to 2 months prior to pregnancy or conception. And a patient should have the HPV vaccine delayed if they do not have it and they become pregnant. So specifically, make sure that the patient has gotten their measles, mumps, and rubella vaccine, their varicella vaccine, that they're up to date on their Tdap, though all women get a Tdap booster during pregnancy, and then also the HPV vaccine are recommended by ACOG. Also reviewing previous gestational history and complications, specifically things like gestational diabetes, as those can be red flags for you to screen patients on either looking at their blood sugars earlier on prior to conception and thinking about ways that you can minimize other risks for their pregnancies. Also, counseling patients on infertility is important. Oftentimes, women will think that they are infertile or cannot become pregnant because they have been having unprotected intercourse for a few months and haven't become pregnant. So the current definition for infertility is that patients will need to have had unprotected intercourse for 1 year prior to meeting the definition of infertility. Though above the age of 35, and any woman who's having unprotected intercourse for 6 months should get an advanced workup or expedited workup for infertility due to their advanced maternal age. The chance of a normal couple conceiving by 3 months is anywhere from 20 to 37%, and by 6 months, it's 75%, and then it's 90% at 1 year. 20% of infertility cases are due to the male factor alone, and 30% involves both the male and female factor, and the rest is the female factor. And then patients who are desiring pregnancy should be counseled that the fertile window is having sexual intercourse in the 3 to 4 days before ovulation, and that intercourse every 1 to 2 days yields the highest pregnancy rates. Patients should also be screened for HIV prior to pregnancy. And if they do have HIV, the goal is to have an undetectable viral load prior to conception. HIV discordant couples should be counseled on HIV prevention, and specifically Truvada is likely safe prior to and during pregnancy. HIV positive women should also be started on and continued on antiretroviral therapy during pregnancy to prevent vertical transmission. And finally, smoking and drug use counseling. This is intuitive for us. We all know that smoking has effects on the placenta as well as the fetus. Things like intrauterine growth restriction can occur, abruptions. There's also preterm, pre-labor rupture of membranes, low birth weight, and increased perinatal mortality associated with smoking. Children born to women who smoke during pregnancy are also at risk for asthma, colic, and childhood obesity. And smoking, there has been studies that pregnancy does motivate women to stop smoking, and that 46% of pre-pregnancy smokers quit during pregnancy, which is quite impressive, I found. The last inhaled substance that we should touch on briefly is just marijuana, and that there hasn't been much data on marijuana use during pregnancy, but it cannot be ruled out as a harmful substance. So often we will counsel, or I will counsel women to reduce or stop smoking marijuana during pregnancy if they're using it. Okay, moving on to case 2. Pam Beasley is a 33-year-old woman who wasn't planning to become pregnant, but turns out she is. She has diabetes and hypertension. She's on metformin and lisinopril and has had blood pressures, usually in the 140 systolic at baseline, and borderline high blood sugars when she checks. So let's touch on obesity and pregnancy. The most common medical condition of women of reproductive age in the United States is obesity. It's 39.7% of women aged 20 to 39 in the United States. We should counsel women that they should attempt to obtain a normal BMI prior to pregnancy. And if women do obtain a bariatric surgery or undergo bariatric surgery, they should delay pregnancy for 12 to 24 months after surgery, because that is the time of most rapid weight loss, and patients should have normal nutritional status prior to becoming pregnant. Obesity is related to myriad different effects during pregnancy, including subfertility, gestational diabetes, hypertension, a higher increased risk of a cesarean section, preeclampsia, birth defects, and thromboembolic events. Specifically, some of the congenital abnormalities are noted here on the right, and the odds ratios are increased for many of these congenital abnormalities for women who are obese at the time of conception or during pregnancy. One thing more to know about that is that obesity also increases medical conditions for women just themselves, including cardiovascular disease, diabetes, et cetera, which can have effects on the woman during pregnancy. The weight gain recommendation for patients who are overweight, BMI 25 to 29.9 is 15 to 25 pounds. And for a BMI of greater than 30, it's 11 to 20 pounds. Conversely, for underweight women, the goal weight gain is 28 to 40 pounds. That's for under a BMI of 18. And for a normal weight individual, the weight counseling gain should be 25 to 35 pounds, according to ACOG. And also conversely, low BMI women also have risks during pregnancy. So they have a higher risk of small for gestational age fetus, as well as low birth weight infants. Briefly touching on pre-gestational diabetes, we all know that diabetes is associated with congenital abnormalities, including macrosomia and pregnancy complications. The goal A1C prior to conception is less than 6.5, so tight control per ACOG guidelines. If you're having patients check their blood sugars, their goal fasting blood sugar should be less than 95, and their 2-hour postprandial goal should be less than 140. Insulin is our preferred agent during pregnancy, but metformin is considered okay during pregnancy if a patient is on metformin when they do conceive and their sugars are relatively well controlled. And we already touched on the complications from uncontrolled diabetes. Okay. Moving on to case 3, Sydney Bristow is a 30-year-old woman who comes in after becoming pregnant. She's on a topical retinoid and has some chronic anxiety and mild depression related to her secret agent job, but is controlled on fluoxetine for right now. She's wondering if she can continue her medications during pregnancy. So let's talk about teratogenic medications. We know a lot of these common medications for high blood pressure include ACE inhibitors and ARBs, and those are teratogenic to the fetus. Also NSAIDs as well. Paroxetine, warfarin, antiepileptics, specifically valproate and carbamazepine, are contraindicated during pregnancy, as well as the mood stabilizer lithium. Accutane and topical retinoids, which we see quite frequently in the young women's population, are also contraindicated during pregnancy and just prior to conception. And then antibiotics, tetracycline, doxycycline, which sometimes are used for acne as well, are also contraindicated. Okay medications are, some of these included here. Our preferred antihypertensive medications are labetalol and methyl-dopa, and then acetaminophen is considered okay. SSRIs are also considered relatively safe in pregnancy, and metformin is considered okay. And Molly, I see your question, why are topical retinoids contraindicated? I don't remember the specific effect on the fetus, but they do relate to some birth defects from my understanding, because there is some systemic absorption of them. I don't know if anyone else has any other understanding of why they're contraindicated. Okay. And then these are some resources for looking up teratogenic medications. These websites, ReproTox, Terrace, and Mother to Baby, can be resources for looking at medications that you're unsure about during during pregnancy. You can also look on Micromedics. Up to Date also has some data on medications if they're safe during pregnancy. You can also look on the FDA website to see what class of medication is. Class A is considered safe during pregnancy, B is possibly safe, C is likely unsafe, and D is unsafe. And then an X medication is a medication that is absolutely contraindicated during pregnancy. Next, we mentioned that Sydney was feeling a little bit anxious and depressed, and so we're going to talk about mental health management. Up to 70% of women during pregnancy have symptoms of depression. 10 to 16% of women meet diagnostic criteria for depression during pregnancy. Untreated depression can have an increased risk of maternal self-harm, infant neglect, prematurity, and low birth weight, as well as fetal growth restriction. And antidepressant side effects They do exist, though. Generally, we're taught that we should advise patients, if their depression is well managed on an SSRI, to continue on that through pregnancy, as pregnancy can be a stressful time in a woman's life. But there is some side effects, including decreased fecundability, the probability of achieving a pregnancy with one menstrual cycle, and increased anovulation, which is more likely with antipsychotics, is what I found in the data. In terms of anxiety medications, we should always avoid benzodiazepines. These are class D and class X medications. Buspirone is a class B medication, so it's likely safe during pregnancy, though hasn't been studied well. Mood stabilizers, lamotrigine is the only class C medication. Other mood stabilizers are class D and class X. Of antipsychotic medications, they're all mostly class C, except clozapine is class B, so likely safe during pregnancy. And just looking at the chat here. See, I wonder if women know about non-prescription topical retinoids. I don't know the data on those, though I presume that they're also not indicated during pregnancy or contraindicated during pregnancy. Okay. All right, moving on to our last case here. Juno McGuff, she's an 18-year-old woman who becomes pregnant, but ultimately decides to opt for a medication abortion at 8 weeks gestation. So as internists, we can provide a medical abortion for patients. The indications for a medication abortion is up to 10 weeks gestation, though there is data that it can likely be safe up to 12 or so, but the current FDA guidelines are up to 10 weeks or 70 days, which can be dated via ultrasound or via last menstrual period. The medications that we use in a medication abortion are mifepristone, which is a 200 milligram tablet, which is administered in clinic, and misoprostol, which is administered 24 to 48 hours later. And it's 4 200 milligram tablets. Most commonly, it's for a total of 800 milligrams that's administered at home buccally. I'm just looking at the chat here. Oh, looks like Sarah, you got it. Riga's asked, are there recommended dose adjustments for volume or distribution? I don't know about that specifically. I don't know if you're asking about antidepressants, Riga.
Yeah, I think in terms of dose adjustments, it's you just treat the patient as they're having their symptoms. So you adjust appropriately per patient need and on an individualized way. The only medication I know that you definitely dose adjust is levothyroxine because of increased metabolic demands during pregnancy. You're going to want to be checking TSH and adjusting that, but we're not getting that deep into it. So yeah, sorry.
Thanks, Sarah. I agree. Regarding medical abortions, you can counsel that a patient that their pregnancy should pass 2 to 24 hours after the complete administration of both mifepristone and misoprostol. And that patient should experience some cramping and bleeding that's heavier than a normal menstrual period. Complication rates are pretty low from a medication abortion. 2 to 7 women per 100 women who obtain a medication abortion will need a surgical procedure if they don't pass their pregnancy or if they have complications from heavy bleeding. Contraindications to a medication abortion, which is probably one of the most important things we should be thinking about when considering a medication abortion for a patient who is looking for one, is greater than 10 weeks gestation, though likely it's safer up to 12 weeks, though currently just 10 weeks for us. Presence of an IUD because you can risk expelling the IUD, ectopic pregnancy, adrenal insufficiency, bleeding disorders, or a patient who's on anticoagulation should not have a medication abortion, and then porphyria. And then for patients following up after medication abortion, they should return if they're having fevers for greater than 24 hours. If they're soaking through greater than 2 pads per hour is the guideline, but though if they're having very heavy menstrual or just bleeding related to the medications, they should return. If there's no bleeding, conversely, the patient should return because they likely have not passed the pregnancy, or if they're having significant abdominal pain for over 24 hours after misoprostol administration. An IUD can safely be administered 7 days after misoprostol administration, but a pill, patch, or ring can be started on the day after getting misoprostol. And then intercourse is generally counseled to be safe 72 hours after administration. And then if the patient doesn't have any bleeding, there's a few different things you can consider, though generally I would probably refer the patient to gynecology or Planned Parenthood. You can consider giving the patient an additional misoprostol dose. You could refer them to a clinic that provides an aspiration abortion, or you can wait up to 24 more hours to see if the patient is in early pregnancy to see if they will pass it. There are a few different providers of both medical and surgical abortions throughout the Seattle area, and so I just wanted to highlight these. Of course, all of us can provide medication abortions, so I didn't include all of our clinics in here, but consider yourself a provider as well. The UW Northgate Clinic can provide both medical and surgical abortions, the Harborview Women's Clinic as well, UW Medical Center, Cedar River Clinic, Planned Parenthood, which is located in the Central District of Seattle, and then a clinic called All Women's Care up in Northgate as well. Okay, our takeaways for today are to consider preconception counseling as medical optimization and risk management prior to pregnancy. Discuss the indications of key medications and whether there are non-pharmacologic alternatives for patients when you're reviewing their medications during preconception visits. Shoot for an A1C goal of less than 6.5% for patients who have pre-gestational diabetes, and insulin is the preferred optimal agent for blood sugar management during pregnancy. We should treat depression prior to and during pregnancy, as untreated, uncontrolled depression does have risks to both the mother and baby. Also consider if a pregnancy is desired and whether a patient is considering a medication abortion. Oftentimes I'll ask patients if they are pregnant in clinic, how they feel about their pregnancy to understand if it was planned, unplanned, or a wanted pregnancy. And then you can also provide a medication abortion for patients up to 10 weeks or 70 days gestation. So I just wanted to acknowledge Addie McClintock and Alexandra Bakarik, who helped in providing some resources and guidance for this presentation. And I'm just catching up on the chat here. Hillary says Virginia Mason does not provide abortion services. Now they're merged with Franciscan. Yeah, I think it is harder and harder to find abortion providers in Washington State, as many of our hospitals are being acquired by Catholic-based health systems, unfortunately. Let's see. Okay, any other questions that I can answer?
Molly, go ahead.
I was going to say, Molly had a question in here, just wondering if there's been any movement among local providers to do some advocacy with Roe versus Wade being reconsidered.
I don't know about that. I'm sure there are opportunities.
I'm not familiar with anything in particular that's going on at the University of Washington.
Yeah.
I know Leah Carlson mentioned that she was at the State House maybe today actually, or yesterday, for an ACOG advocacy day. I don't know if specifically about abortion.
Yeah, I was gonna say, can you see me?
Yeah.
Okay, so I have lobbied with ACOG the past couple of years. This was actually a point of contention last year more in one of the bills that they lobbied for, wanting them to have to do like a impact assessment whenever there were mergers. I don't think it ended up passing. But overall, if people are interested in it, I would advise joining the Reproductive Health Action. I can't remember the last word, but it's RAP. So capital RHAP. And then because they send me links about like things that you can sign and different petitions. So highly encourage, very easy way to get involved.
Awesome, thanks, Leah.
Cool, and I just wanted to make a statement, Sylvia, awesome presentation. In terms of preconception counseling, we talk about prior pregnancies being a risk factor for future pregnancies. And so I just want to make a plug to you all to take a really good pregnancy history. It is not that much work, and it is more than just saying how many times have you been pregnant and how many babies have you had, vaginal or cesarean. I think a lot of women don't recall really. Like yesterday I had a patient where I was like, any complications? And she was like, no, I had a C-section. And then I dug in a little bit more. She had preeclampsia. and getting at like, oh, elevated high blood pressures in pregnancy, any elevated blood sugars, things like that, just because not only does it predict future risk with pregnancy, but it also predicts future cardiovascular risk. And so as an internist, that is like, should be particularly interesting for us. And just make sure that we're getting a little bit more details. It doesn't take a lot of time. So just push a little bit more to get that history.
Thanks for that plug, Sarah. All righty, I'll hand it off. Thanks, everyone.